very much, Ed. I appreciate that. I'm always honored to join the GPLI webinars. It's fun working with Sue and Ed and the whole group. As Ed mentioned, please, if you have questions, bring them forward, and we'll do all we can to answer them for you. First, the obligatory financial disclosures in the previous 12 months, GPLI Advisory Panel, Vision Expo CE Advisory Board, columnist for the Spectrum, as Ed mentioned, but I do not own stock or have financial interest in any company mentioned here. Now, a quick few minutes on the basics. Of course, astigmatism, as we know, is when we have different foci propagate in two perpendicular planes. Now, of course, that is what we call regular astigmatism. It is most commonly corneal. Refractive astigmatism present after neutralizing the corneal astigmatism we generally refer to as residual astigmatism. It may occur in the cornea, crystalline lens, theoretically even the retina, albeit it would be very, very small. In the cornea, we have to pay attention to both the anterior and the posterior. And in keratoconics, for example, the contact lens will correct the anterior irregular astigmatism, but we may still have some posterior component which may not be fully corrected. We know that in crystalline lens, as it becomes cataractous, as the crystalline lens matures beyond presbyopia into the cataractous state, we often will begin getting some irregular, some against the rule astigmatism. Now, irregular astigmatism, which is the topic of this talk, is when the principal meridians are not 90 degrees apart, something other than. And often we have actually multi-axes of astigmatism. We still have primary axes. Irregular astigmatism causes and indications. Ectasias, keratoconus being the primary, depending on who you read, pellucid marginal degeneration is likely just a type of keratoconus. Post-surgical, RK, LASIK, corneal surgeries, penetrating full lamellar keratoplasties, intracorneal length segments, scars, eyelid lesions, for example. Something as simple as a chalazion can create irregular astigmatism in the optical system. Easily diagnosed if that's what's going on by just lifting the lid off of the cornea and seeing if it self-corrects. And ocular surface diseases. By far the most common form of irregular astigmatism is keratoconus. Now I want to mention something about corneal scarring because in keratoconus management it's very, very important to minimize corneal scarring and to realize that corneal scarring occurs with or without contact lens wear. Some believe that contact lenses are necessary to cause scars, and that's just absolutely not true. They can occur with or without contact lenses. However, having said that, an ill-fitted contact lens can exacerbate and propagate scarring. It's very important that we tell keratoconic patients, do not rub your eyes. We know definitively now that by rubbing the eyes, there are enzymatic activities that are released that actually thin and exacerbate and propagate the keratoconus thinning of the cornea and scar tissue formation. Rubbing is really a no-no in keratoconic patients. It helps for us to understand how scarring occurs as to how to prevent it. Scarring occurs when the corneal epithelial cells come into contact with the stromal keratocytes, and that requires a full thickness penetration through the corneal epithelium. For example, in LASIK surgery, part of the beauty of LASIK is that it doesn't scar under the flap. The scar is only seen at the slit lamp at the wound. That's where the epithelium contacts the keratocytes, and the only place the scarring tissue will be seen. There is no scarring underneath the flap. It actually does not scar and does not heal under that long term. This is because in keratoconic patients, they have reduced protease, reduced enzymes enzyme inhibitors in the epithelium, so that these inflammatory enzymes that can be activated by eye rubbing, for example, can thin the cornea, and that by reducing the inhibitors, they're not kept in check. These patients also have an excess amount of collagenase, the enzyme that actually lyses collagen. The keratocytes die off prematurely, premature apoptosis. And the keratocytes have increased binding sites, and that is they become more active more readily. Feather touch is a phenomenon of corneal GP lens fitting, which has been around and traditionally the best method for fitting keratoconic patients to give them good vision. It requires a light touch. Feather touch is still used, but it must really be a light, smooth touch requiring full exchange of tears with each and every blink to prevent the scar tissue formation. Again, very, very important. So that's it for the basic science review. The key to successful keratoconus management is choosing the appropriate form of vision correction for that individual patient. Irregular astigmatism management, do nothing. In medicine, doing nothing is often a good thing. In keratoconus, not so much. Spectacles are limited to early keratocones. Contact lenses have the ability to correct both regular and irregular astigmatisms. Surgery may or may not be beneficial. Intracorneal ring segments, ablative surgery, which has actually been used and not with good results. Corneal cross-linking with riboflavin is very, very promising. Partial penetrating keratoplasty if necessary, or a combination of these. Among our contact lens options, soft lenses, either heme or silicone hydrogel, toric designs. We may have a patient who is an early keratoconus patient who is a high myope, and we can correct the high myopic component with a spherical, even daily disposable contact lens and a spectacle overcorrection. This may work early on. GP lenses have been the traditional, and GP lenses remain the best correction for keratoconic treatment. Piggyback of both soft or tandem soft GP fit, hybrid lenses, and scleral GP lenses. When you see this pretty picture of the beach, it's giving Ed a chance in case he wants to offer any or take any questions. So as we go on here, the first case report. The 22-year-old male college student presented to me complaining of decreasing vision, halos at night, and complaining that he was just visually non-functional. He had no significant past medical history and took no medications. He had a past ocular history of having been diagnosed with keratoconus with a, quote, intolerance to RGPs. He sought a fix for his keratoconus, and it presented to me after having undergone corneal surgery, conductive keratoplasties, keratotomies rather, cross-linking, and intracorneal ring segments. He went onto the internet, actually his mother went onto the internet and found a site that could, quote, fix his keratoconus and leave him with this dastardly disease forever. And he went out to the West Coast to have this taken care of. When he presented to me, he was status post C3R, which is a branded form of epithelial on corneal cross-linking with riboflavin. He had superior located dots of conductive keratotomies and intact intracorneal ring segment placement 4 months prior to his presentation in my clinic. He was currently wearing soft hydrogel contact lenses, and his vision upon presentation was 20/100 in the right eye and 20/70 in the left eye. And again, he was just basically not functional, quite frustrated. His keratometry was approximately 53/56 in the right eye, 47/52 in the left eye, 2+ Meyer distortion. The rest of the eye examination was unremarkable. Here are his maps. Now you'll note here, you can see where you still got a central apical steepening, quite a bit of steepening here. And this is where the inferior intact placement is located on the right eye, and similarly here on the left side. You still got, this is a 3mm, 5mm, and 7mm out from the optical axis circles. Most of the information, of course, is located in the central 3mm. And the central 3mm remains quite aberrant in shape. The ophthalmic exam, the anterior segment was significant for superior scarring, and you can see here these are the scars left over from the CK. And inferior placement, this is a single inferior placed intact intracorneal ring segment. The dilated fundus exam was unremarkable. Here you are again, superior CK scars. In each eye, he's got a single intact. The intracorneal ring segments are made of polymethyl methacrylate. They've been around. They were first used to correct just mild to moderate myopia. It was found out that they could significantly alter the corneal curvature and possibly be helpful with keratoconus patients. And they were indicated in patients, keratoconic patients, who were otherwise unable to wear gas perm lenses. It produces a shortening of the central arc length proportional to the thickness of the segment. The central portion of the anterior surface of the cornea tends to flatten while the peripheral cornea steepens or the segments are displaced forward. There are different types, intact being the most common in this country. And you can see this is a Keratone here, which is triangular in shape, and the intact, which is hexagonal in shape, seen on these OTCs. The arc length and thickness varies according to the patient's refractive error. The key is to flatten this arc and therefore give better vision. But as you saw from our map, that didn't happen for this unfortunate patient. On average, there's about 3 diopters of shift, which is not a lot for the keratoconic patients, where your Ks, which go from normal-ish from 43 diopters to well in the 50s and higher, 3 diopters of effect may not be adequate. Increased thickness increases the focal steepening, which in turn flattens the cornea centrally. And again, you can see the difference in a couple of different types of rings here from these OCT images. Now this is a different patient of mine, and I just wanted to show the difference between the preoperative keratoconic fairly central cone of this patient, and then underwent bilateral or double intact, one above, one below placement, and you can see the problem is that he still has keratoconus centrally, but now he's got this raised LASIK-type wound way out in the periphery. When you think about that as a cross-section, that makes it much more challenging to fit with a corneal GP lens. Most patients are supposed to be told, of course, that they still may need contact lens fitting for the best corrected visual acuity following these intact placements here. But it does decrease some of the irregular astigmatism rather, and allows a little better vision as far as refractive for glasses is concerned. There are complications. Sometimes they extrude through. Explantation varies from 1 to 30%. Glare halos photosensitivity, and some require further adjustment. The other part of this patient's medical treatment had to do with conductive keratoplasty, and that is using a high-frequency energy to reshape the corneal, and that is by using a probe and by creating scarring. Scarring causes a belt-tightening effect of the curvature and tightens it up. It shrinks. What scarring does, just shrinks the surrounding tissue. So he had that done as well. Now back to this gentleman. He remained intolerant to corneal GPs following intact placement. Although the patient was in soft torics, he did not have functional vision when he presented. He wanted to be able to drive. So he elected to go with the scleral contact lens. No corneal contact and improved comfort were the goals. He was seen by the corneal service, which decided that there would be no benefit in removing the implants, and there would be additional risk to open the cornea to remove it. Now, often these patients are told that, well, if this doesn't work as well as we want, we'll just take the intacts out. But you really can't create a canal in the cornea and expect it to go back to normal after removing the implant inside that canal. It doesn't quite work as well as hoped. The best correction options included scleral lens, piggyback, or custom hydrogel, or silicone hydrogel. I elected to use a scleral lens in this particular case for the obvious reason, because if you think about putting a corneal lens on this tissue, you would have the cornea with the intact is placed about halfway into the corneal stroma. If you put a rigid lens that rides on top of that, you're going to be pressing on that corneal tissue from the top with the contact lens, rigid contact lens, and the rock, if you will, on the inside in the cornea itself from the intact. And that creates problems long term. So being able to vault totally over and not have any corneal touch. This particular gentleman used a 16.8 millimeter lens, had a 4 diopter reverse curve on it. You can see the various peripheral curves, increased flattening out to the periphery. His RX is about 12 afterwards, and fortunately got very good vision. Got 20/25 plus in the rod and 20/20 minus. And I saw him just recently in a 12-month follow-up again. He continues to have good vision and comfort. He's moved out of state now, but still comes back to see us. These are references which you can check on the website. They'll be available to you if you want to peruse these a little bit more carefully, having to do with this particular case. Ed, did you have any questions, comments about this type of a case?
Well, you know, to me, that's excellent. It shows a great example of where you can use scleral lenses, particularly in a patient who is GP intolerant. And let me throw an impossible question at you, Michael, that I have probably presented every time we have an Irregular Cornea webinar, because I always want to get a feel for where people are coming from. You fit so many irregular corneas at Emory. If, let's say you have 100 patients that you fit in who are irregular corneas, it can be keratoconus, you know, any other, you know, modality that's resulted in irregular astigmatism. What percent do you fit into a small diameter GP? What percent into intralimbal? What percent into scleral? What percent into piggyback? What percent into soft? Your thoughts?
You're right. That is an impossible question.
That's why I asked it.
But patients who come in who are keratoconus wearing corneal lenses today and doing fine, I do not refit them. I leave them alone. New cone patients are pretty much given a choice. If they're mild to moderate, we could use a custom soft. Most of them go into scleral. So the primary, sort of the state-of-the-art, in my opinion, of keratoconus management in 2014 is scleral GP lens fitting. So that's my primary on new folks coming in. Again, if they're doing well, or if they just don't want to, we'll leave them in the in corneal GPs. And in some patients who are just, and I've got one of these cases, just wants something soft. And of course, since most of the contact lens world is soft, that's understandable if they come in with these free notions about that.
What about hybrids, Michael? Are they part of your?
We use hybrids, but low. It's in the single digits. We use piggyback. Was more common before we had sclerals. There's less need for them today.
Okay. No, very good. I don't see any questions up yet. I'll make a couple of comments and then we can go on. Always want to recognize our advisory board members. In addition to Michael Ward, we have Mike Lipson and Susan Gramacki here tonight. Another reminder, any day now, our laboratory consultants module is going to be launched on gpli.info, and so often we really need our lab consultants in every phase of patients like Michael was talking about tonight. And so we are launching an FAQ section for the 20 most common questions that laboratory consultants receive, and we have multiple answers to each one of those questions. So look for that in the next week. Also, as it pertains to irregular cornea, we have a lot of archived webinars pertaining to every phase of irregular cornea, and we also have a 4-lecture series from Christine Sent on keratoconus that if you haven't had a chance to check it out, I think you would find to be very helpful. With that said, Michael, go on ahead.
All right. Thank you, Ed. Next case report. Very recent. 72-year-old female presents complaining of decreasing vision in the right eye for the last 16 months since she had undergone cataract surgery. Past doctor history was positive for keratoconus, which she'd been diagnosed, she said, approximately 4 years ago. most recently cataract extraction and intraocular implantation in the right eye. And she says, I'm not having the left one done. And I'm sure others have heard this. Once they've had a bad result, a questionable result in one eye, they're going to leave that other cataract alone until they absolutely have to do something about it. Wears spectacles and had never worn contact lenses. Refraction, minus 250 plus 375 against the rule with a 20/80 on the right eye, minus 1.5 plus 1.5 in the left eye with prop 20/20. And that's, the left eye is unoperated at this point. The right eye was the more significant irregular astigmatism eye. It's a picture of her cornea. She's got a little bit of haze. That's about it. There's no, there is an apical scar with some haze present there. This nodular apical scar. Now, when an apical scar becomes nodular, that's where it becomes soft. You have a hyperplastic situation. So you have this epithelial hyperplasia that's a soft, that's not bound down very well to the basement membrane, and it's very easily damaged. And that will lead to scar tissue formation as you upset that nodule. And she had been, she had been offered corneal GP's custom hybrid or scleral. And this particular lady really wanted to go with a hybrid lens. So put her in a clear cone at the time, and she ended up with medium skirt, 350 plus 3/4, 20/25 minus 2, good vision, good comfort, full wearing time, and did quite well with that. That's what she looked like with the lens on. And what was nice about it is we were still able, even, and if this was done today, I probably would have started with a scleral lens, but she really, when given the option, she really wanted to go with a hybrid. Sclerals were earlier on there. But it's really great to be able to offer that. And this is a very interesting case. Now, as we go along here, Ed and the others, see if you can figure out what's going on before we come to the bottom. 26-year-old pathology resident who'd been diagnosed with his previous institution with keratoconus, presents complaining of blurred vision, once soft contact lenses. He had historically worn spectacles, and soft contact lenses. Last wore soft lenses approximately 4 months ago. He states that his visual acuity has always been less than 20/20, and he really doubts that it's changed very much. Now, he's a pathology resident, which means he's going to be wearing a shield, a face shield, during most of his working day when he's in the lab doing pathology specimens. Refraction was minus 2 sphere on the right, minus 350 plus 1 on the left, but couldn't correct him beyond 20/30 with a straight refraction. Keratometry was not that unusual. It's mild, very mild with the rule. His corneas were absolutely clear. There were no stria, no Fleischer rings, no scarring, no thinning was noted, and the rest of the ophthalmic exam was also unremarkable. So looking at his topographies, this is the right eye rings, pseudodisc rings. Now here's where it looks like he's got superior keratoconus. Left eye. So ask yourself, what's unusual about that? Keratoconus generally occurs below the midline. Now look at the symmetry between the two eyes. Very high symmetrically. Now, this is the giveaway. Look at his eyelids. Now, he was diagnosed with keratoconus at his previous institution. What he really has is blepharoptosis-induced corneal steepening. This is where the upper lid is pressing, he had congenital ptosis, is pressing on the cornea and pushing those cells downward, actually causing a steepening of the cornea in a ridge-like fashion. And this is because the maps show a steepening, is why I suspect he had been diagnosed with keratoconus previously. No other clinical signs were present. So the assessment was a blepharoptosis-induced corneal steepening with mild irregular astigmatism, no positive slit lamp findings. Refraction and keratometry were not indicative of irregular astigmatism. Corneal topography was key in the diagnosis, as was using the pinhole. Although the GP lens would provide the best acuity, as we discussed this with him, He was satisfied with daily disposable lenses for occasional use. Again, he's a pathology resident, will be a pathologist. We're spending a lot of time in the laboratory, and he'll be wearing a face shield. So he doesn't really want to wear contact lenses during his office hours. And of course, our oculoplastic service offered that upper lid blepharoplasty would correct this, as it would. And references on this. Any questions?
No, that's an interesting case. I was thinking superior fit. You know, I was thinking the lenses were causing that. But once you showed the lids, you're right.
There was your giveaway.
Yeah, that's a great case. We
Yeah,
do have Cynthia has a question that's very kind of along the same lines a little bit. It's a good question. Has a patient with a 7th nerve palsy after facial surgery, lax lower lid, severe dryness, attempted a scleral fit, but the lid weight pushed the lens too far inferiorly, tried 14 millimeters to 18 millimeters sclerals, tightening scleral zone enough to prevent inferior decentration led to vessel blanching. Any suggestions? In other words, you know, was able to move the lens in a position where it's centered well despite the lids, but to do that, you know, it caused peripheral tightening, vessel blanching. Any suggestions?
Yeah, a couple of questions. First, does the patient have a gold weight in the lid? Because sometimes these patients, if they're having lag ophthalmos, they'll put in a gold weight after nerve palsies.
I'll wait and see if Cynthia comes.
Yeah, if that is the case, then of course that's one way to think about it.
Yes, she does. She does.
Yes.
Good call.
And that weight could possibly be decreased. Yeah, it's another surgical procedure, but could be decreased. The other thing, of course, is to use a toric peripheral curve, secondary and peripheral, not just secondary, but peripheral curve, all the peripheral curves in a toric fashion, and have enough toricity that you can dial it in and keep that lens better. Now, you're still going to go large, and you're probably going to go even larger than an 18. Here's where going large really does help to stabilize that thing on the eye. But again, I would really look at the sclera and see where you're having your blanching. Is it only in the superior arc, or if any one of the other 3 quadrants is involved? And then talk to your laboratory. There are many labs, or some labs at least, that will work with you in quadrant-specific configuration on the sclerals as well. And that's what I would try, is use your laboratory consultant. They can be quite helpful in designing these things for you. Good question.
Yeah, that's a good answer. I think certainly if you can take any photos, anything you can provide the lab to show where possible blanching is, the quadrant or quadrants, it is amazing what the technology is today with toric. More and more experts are just recommending toric PCs in many of these cases, and then of course the quadrant technology is available. So that's great.
Yeah, we've got some great technology available today. It's great to live during this time and have all these tools available to us. All right, moving along. The next case report. 52-year-old male lawyer presents complaining of shadow images, blurred vision, right greater than left, wants to return to soft contact lens wear. Has a history of having had LASIK surgery, first in the 1990s. I saw this guy yesterday. PRK enhancement in 2005, soft lens wear prior to surgery, and a history of GP failure, corneal GP failure. His uncorrected visual acuities are 20/200 in the right eye, 20/30 plus 3 in the left eye. Here's his refraction, spectacle refraction correction of 20/40 and 20/20. Fortunately, his left eye is good. Keratometry is not that absurd. Slit lamp, LASIK wound scars were present, much more prominent in the right eye, with 1+ central haze in the right eye as well, otherwise within normal limits. Here were his topographies post-LASIK, and you can see with the right eye, again, the middle circle is 3 millimeters, the middle one's 5, and the outside 7 millimeters on visual axis. And of course, the money's inside the central 3. And you can see the central 3 on this right eye is where he's got some distortion, and he's got some peaked islands. In the left eye, he looks pretty good, which is why he's got good refractive vision in the left eye. Trial of soft contact lens toric, 2030-2025, complaint of ghosting in the right eye, which it was not corrected by using a soft toric. So went to a scleral, he got 20/20 in both eyes. Comfy, but still feels it. Complained that he still felt the contact lens, saw great, loved the vision, but he still had an awareness of the scleral lens on his eye, as you can see here. So 2012, he came back. I have been seeing this guy over the years. I saw him again yesterday. Made me think of him for this particular presentation. So he came in 2012, and this is when the Kerasoft and Novacones were coming out. So I fitted him with a custom toric, a Novacone, in the right eye and a daily disposable in his left eye. The Novacone was an 868615 and IT1. These parameters gave him good vision, 20/20 -1. AccuView moist on his left eye, 20/25, and he's happy and comfortable. He's really sensitive. I mean, he had a great-looking scleral fit, in my opinion. No blanching. Eye was white and quiet. No inflammation. Nothing to see, but he felt it. Here's his cornea on the right eye. And then on the right eye, over the Novacone, which is really important, the reason I show this slide is that you want to use either your topographer or your keratometer to look at a soft custom lens over, use your topography units, over the soft lens to see what kind of irregularity may still be coming out. Again, look in the central 3 millimeters here. It looks really good. There's one little island. Other than that, he looks really doggone good looking over his custom soft toric. So he comes in yesterday. No complaints. I think I need new lenses. Now look at the picture. If you can see it well enough, lots of little dots on it. Those are all what we used to call jelly bumps, deposits. I think I need new lenses. He had gotten a 4-pack of custom toric lenses back in 2012 for his right eye. He claims replacing the daily disposable in the left eye every day. But he's been extending the life of this particular lens. So you can see here better, again, contact lens deposits, and he's using clear clear. He's using hydrogen peroxide. Imagine what that would look like if he wasn't. But the point being, these folks are told to replace these every 3 months. It's hard to make people replace them every 3 months, but it's really important to do so. Fortunately, when you see something like this, you've got to be sure and flip the lid and look for GPC. He's a sitting duck for giant papillary conjunctivitis if he doesn't keep these things clean and replace them as he is supposed to. So I think we need a better system, my office needs a better system on how to monitor these folks and make sure they're replacing the lenses on a more regular basis. So diffuse lens deposits, no GPC, using peroxide already, so we just ordered him some more lenses. Any questions? We'll move along.
No, that's a good case. There is one point I'll mention is just to throw at you, knowing that these patients and that patient could see relatively well. It seemed like, if I remember from the
it wasn't terrible.
But these patients typically just live in their lenses in terms of wearing them every waking hour and maybe a few non-waking hours.
Right.
For example, for your keratoconic and post-surgical patients that you fit into GP lenses, and we know sclerals are in hyper decay materials, but for your non-scleral lenses, what type of decay material do you like to use for those individuals?
I went very high, typically 100 or higher decay materials on the sclerals, and most of them are, so there's really not much of a problem. We used, BXO, BXO2 are probably the two primary plastics, and then we use Contomac as well. That's primarily what I'm using now. What about you, Ed?
Well, it's a good question to raise because I've always tended to go a little bit on the lower side, and I always remember just because of the rigidity. But it, there's a good argument to especially post-surgicals, to go exactly the way that you're going. And I know I had that debate with Rex Gormley when he was still alive because he fit everybody in the Minicon. And I just like the rigidity of like the 30 to 60 DK materials, but I think today, with the fact that the hyper decay materials are manufactured so well, they're so stable,
Yes.
they're, resistant to warpage and more scratch resistant than previous generations, that you're certainly right on in terms of thinking of hyper decay materials for these people.
Well,
it gives you that wiggle room.
Yeah, and to your point, you're looking at the thickness of these things are usually 0.3 and greater millimeters, usually 300 microns and greater. And when you go, the decay value is based on a 0.1. So if you're at a 0.3, you're only getting a third of whatever that number is. And of course, that's just central if you're measuring centrally.
Yeah, particularly
the same the math
sclera.
pertains. Yeah, but there is some dynamic tear exchange we have to remember here. These are not static, and the tears do still, even though you got a seal to maintain fluid level, there is a dynamic equilibrium of tears. So you still got, as we see, the MGD debris coming in under these lenses, and you would think that you need. It's nice to think about having some metabolic waste turnover, but this time you're getting waste influx with the MGD patients, and that's been a problem with the sclerals.
How often do you recommend replacing sclerals for patients to replace them?
Well, that's a good question. I tell patients, because it's usually it's in the upfront conversation, how long do these things last? I tell them we expect 2 to 5 years. So that may be extending it, but I'm thinking, I'm telling them a couple of years.
Do you have much problem with flexure, Mike, in your opinion?
No, and another good point. We always do K readings over the lenses to see if we have flexure. And just like whenever you question it, now, usually you'll pick it up on your retinoscopy when you're refracting the patient over the lens. And usually when you do, it's against the rule. If you see the streak against the rule, then you want to be sure and take a K reading over that and make sure are you flexing or not. And then you don't have to necessarily thicken it. Sometimes you can just reconfigure it without actually having to thicken it. And again, this is where your laboratory consultants can really be helpful in designing the mid-periphery and periphery of these lenses, because they can thicken it where otherwise you might be thinning it on the way out into the periphery and keep it from flexing. You may just have a more scleral, a more toric sclera that you've got to deal with and contend with, and in which case using toric peripheral curves can prevent the flexing. So again, you don't necessarily have to thicken it here.
No, that's a good point. The toric BCs are changing the other lens parameters.
Okay, usually it's because of a tight lid and a toric body, the globe itself, that's pressing and creating or inducing toricity into the system.
Okay, well, very good. Michael, continue on.
So one more here, not the last, but the next one. 30-year-old female presents complaining of decreasing vision, multiple images, needs to see better, history of keratoconus, currently wearing spectacles, tried GPs 4 years ago without success. When I say GPs, I'm meaning corneal GPs. Vision with current spectacles, 2015, 2025. Here's the refraction, not too unremarkable. Keratometry, 46 over 51, 44 over 48. By the way, I've always thought it's interesting to note that in keratoconic patients, typically their astigmatism starts with the rule and moves towards the oblique axis as the keratoconus progresses. Whereas in pellucid marginal degeneration, it's always against the rule. Little pearl there. Slit evaluation, mild ovate stria, slight haze, mild subepithelial apical scars. Here's topography of the right eye. You can see just paracentral apical scarring, or apex here. Left eye, fairly symmetric as well. There are the bilateral topographies, again, both very central. And you can see on the left eye, you have some, what I refer to as macular sparing, like you would on a visual field. A little macular sparing right there in the middle, which is why this left eye sees so much better than the right eye, where the visual axis is really more obliterated by the larger area of red that we see there. Initial fitting, uh, corneal gas perm lenses in 11.2 millimeter diameters. Got 2040 and 2025, relatively standard peripheral curves. But I was bothered by that. Looking at the eye, I should be able to get better vision than this. Manifest refraction over the contact lenses provided right eye plano plus 250 to 180. I've got against the rule 2.5 diopters a cylinder. Also 2.5 diopters a cylinder on the left eye, also against the rule, providing very good vision when it's fully corrected. So here's what we were just talking about. Keratometry over the corneal GP lenses was spherical, no flexure, meaning those drum readings were exactly the same on both sides. That's a very important point. Now here's where your laboratory consultants can be quite helpful. So you can take the information, you can refit them if you want to, or just call that in, and your consultant can take that information and design these for you. Here I put in toric PCs, some prism ballast. Now the amount of prism ballast, because it's a front surface toric, so we're putting cylinder on the front surface of this corneal GP lens. Therefore, I've got to be able to orient it at its axis, and it's done that by weight. Ballast is the operative word here, not prism. Prism is just sort of the shape. And 3/4 of a diopter is sort of the minimum. And since this is a plus lens, that should be fine. You may need more than this, maybe up to 1.5 diopters if you're going with a high minus lens with cylinder on the front surface toric. In checking for residual astigmatism, the GP will neutralize the anterior corneal irregular astigmatism. So again, the GP lens is going to neutralize the anterior corneal astigmatism, but then you got to check for residual astigmatism by doing a refraction over the contact and doing keratometry over the contact to check for flexure if you pick up any astigmatic component. In fitting the front surface toric, consider toric secondary and peripheral curves, typically 3/4, 1.5 prism ballast, and again, use your consultants to help you out here. In using corneal GP lenses for irregular astigmatism, we have standards, and in early keratoconus, use a standard that's what I use, a standard tricurve or an aspheric. Myoflange is a thinning effect, knocks off some mass using the upper lid to keep that lens aligned properly, typically starting with a 9.0 to 9.5 millimeter diameter on these mild to moderate cones. If you don't know where to start on flat K, adjust your base curve and diameter relative to your fluorescein patterns. Your fluorescein patterns are going to drive you as to where you need to go. As an example, if this is the SIM-K 43.5 over 44.7, start with 43.5. And again, let the fluorescein guide you. The movement, the centration, the fluorescein pattern, and then the over-refraction for your actual final lens components. The most common error, I see this all the time in corneal GP lens fitting, is making a lens too tight, trying to fit the apex of the cone. Again, the most common error in keratoconus management is fitting lenses too tightly. If you look at these slides, there is no contact lens on the eye here. This patient came in wearing a rigid gas perm, and you can see this is actually indentation on the cornea. There is no contact lens. The contact lens has been taken off of the eye. Here's a topography of placido disc rings. You can actually see the spherization of the eye centrally. This is where the cornea was made to shape the center of the contact lens, the area of the optical zone. You can actually see where the secondary curve of the gas perm lens has molded his cornea, and here's where his peripheral curve was right here. It was displaced. Often when a GP lens is fit too snugly, it displaces inferiorly. So a number of years ago, I took 50 keratoconus patients and just looked at what are we fitting and how are we fitting in the way of corneal GP lenses. Early on, in the green here, were spheres and aspheric designs. In the moderate keratoconus, all types were used. That's the blue here. And in advanced, there were primarily the more keratoconic specific designs like Rose K, Dynacone Plus, and other types of custom, smaller GP rigid lenses. And this is, I found was interesting. So I wanted to know, what was my fitting relationship on these eyes? Well, relative to flat K is that the relationship of the base curve to the flat K on a spherical design was a minus 0.6 diopters. In other words, I was fitting at about a half a diopter, 0.63, flatter than flat K. On the aspherics, using about a 1.5 diopters flatter than flat K, and about the same for that on the Rose K and Dinah Cone Plus designs. And this is still true today when I'm fitting these folks. This is a good place to start if you don't know where else to start on an early keratoconic central corneal GP lens. Questions?
No, those are good pearls for fitting, when you're talking about the small diameter and intralimbles. And I know today, usually when I throw that question out there to people, we've gravitated so far from just the small corneal lenses to intralimbals, which have been a lifesaver in a lot of comfort situations. And of course, as you indicated, with a lot of the newer patients with, high degrees of irregular astigmatism, that the sclerals definitely have a great place. But those are good pearls for just the the importance of evaluating a lens on the eye and still having your GP fitting skills and their assessment and evaluation skills. So I don't believe we have any questions that I can see.
Now, moving along here. This is a case that actually spans over many, many years. A patient with granular corneal dystrophy. I first saw in 1991 when she was 6 months post-therapeutic PTK on the right eye. And this is when the eczema was just coming out. And if you look here at the refraction, the patient has an aphakic type of refraction now. There's so much cornea removed that they now require an aphakic type of refraction. Very flat Ks here. A large amount of anisotropia. These granules and corneal this corneal granular dystrophy come forward and break through the surface with episodic epithelial breakdown, and this creates a lot of pain. Here you can see a little bit eccentric ring from where the ablation was done on the right eye, and these are raised areas on the other eye from the granules in the cornea. Initially, tried fitting her in a gas perm lens, 20/25 vision, temporary success, repeated epithelial breakdown, multiple refits over the years without success, tried soft torics, tried piggyback, tried hybrid, tried different things. Then back in 2008, now her vision continued to deteriorate, which is typical in corneal granular dystrophy. The vision goes down. It's a progressive condition which occurs in midlife or later, typically. Then she had social issues. She lost her husband, and all of a sudden she, which hadn't driven in a long time, needed to be independent again. So in February 2008, I fitted into a scleral contact lens, and this is one of my earlier scleral fits, and I was just so pleasantly surprised. It's a 15.8 diameter. Here in my peripheral curve, we designed into it at that time. And she was absolutely thrilled. Here's what it looks like. Again, you see these corneal granules coming forward with the haze associated with that. And centrally, this is the size of the optical zone. The optical zone was an 8.8, 15.8 overall lens diameter, and diagrammatically, the different peripheral curves that were placed in there. What the lens looks like on the eye. So I put her in the right eye, which was the ablated eye from the excimer. She was put her in monovision. So with a plus 1150 hydrogel, she's J2, and with a scleral GP in the left eye, she's 20/40, so she's able to drive again, and she regained her independence, and she was absolutely thrilled with that. I'm going to move on straight into the next one here. Tandem lenses. Tandem, soft, and rigid, or piggyback. There are two ways of doing a piggyback lens. Historically, piggyback is not new, been around a long time. Back in the early days, we used piggyback lenses as a stopgap measure before taking a patient to surgery. And the reason was that we didn't have good plastic. The gas perms were relatively low decay. The soft lenses we had were HEMA only, low decay as well. Often it was first generation like polymacon. And the combination just tended to suffocate the cornea, and the patient couldn't wear them for very long at a time. Variable success. Hypoxia was the most common complication at the time. But silicone hydrogel soft lenses have largely solved this hypoxia problem and greatly increased the piggyback lens uses. The purpose is to provide corneal protection properties of a soft lens and the refractive benefits of a rigid lens. Soft material is used to protect environmental debris, minimize foreign body sensation from the presence of the GP lens, and also to provide shape. For example, when using a piggyback is also a good thing to use over corneal transplant. If you have a very flat corneal graft where you have an raised wound and a normal paracentral area, you can actually increase the central thickening, the central curvature, by putting a low plus silicone hydrogel over the eye and give you some actual shape support. Another one is using, when we see these apical nodules I talked about earlier, and these are become quite painful. This is hyperplastic tissue. It's easily damaged, very, very fragile, and the more often this comes off, the more likelihood you're going to get further apical scarring to occur. So indications for the tandem fitting, soft combination, first-time lens wearers. We found years ago, but in fitting corneal GP lenses in first-time keratoconus patients, for example, if we used a temporary soft lens underneath in a tandem fashion, often they wouldn't stay in them. They would use it as a crutch to get to the adaptation and then wouldn't need them again after that. These are also helpful with these irregular corneal surfaces, apical nodules, and post-surgical, and when we have epithelial basement membrane, which is very, very fragile and prone to break down. Two basic methods: design the GP lens to fit the cornea and then dispense it at the time with the soft lens underneath, which is what I prefer. The other is to put the soft lens on the eye and take a K reading over it. More specifically, method one, fit the standard custom. For example, you're going to fit a cone lens, a cone design on that cornea. But then on the day of dispense, you dispense a single-use silicone hydrogel, high oxygen flux material lens under the GP lens. And the other method, this works better in the patient who's had a corneal graft, for example, is put a soft lens on to get a better curvature of the cornea. Take a K reading over that and use your flat K reading of the K reading over the soft lens and use that to determine your base curve. So use, for example, if your K reading has got a flat curve of 7.5 millimeters or 45 diopters, let that be the base curve as you design your rigid lens to go on the top of it. The silicone hydrogel materials, these all work well. Pure Vision, Oasis, Night and Day, Biofinity, True Eye, Dailies, Total One. Again, high oxygen flux. Be careful with the stiffer lenses. For example, the Night and Day, which still has the highest oxygen permeability or gas exchange to the material, it's the highest silicone content, and it's therefore the stiffest lens. So it doesn't drape as well. You can get this fluting effect you want to look for, this fluting or buckling effect coming off the cornea, and that's not acceptable. You need something to lay down better than that. You want high decay rigid materials to use on top. All the Minicon Z is approved for 30-day continuous wear. We do not recommend that. All these materials, the Boston XO, XO2, and Optimum Extreme, are all quite good. And you want a material that that's dimensionally stable, and for the laboratory, one that will manufacture well. And typically, the higher the decay, the softer the material, and the more prone to either manufacturing or handling damage later on. This is just a photograph of a lens with GP lens on top of the soft. You see a apical scar there, right there, in that keratoconus patient as well. But I got to mention something about lens care. It's really important if you're going to fit tandem lenses, soft and rigid combinations, that you do not allow the rigid lens cleaner or the rigid lens conditioning solution to come into contact with the soft contact lens, because it will be absorbed like a sponge into the soft lens and will concentrate those preservatives, which are not supposed to be used in conjunction with soft contact lenses, and can then impact a corneal burn from that. So be very, very careful. In lubricating drops in these, your best bet is using preservative-free. We can safely use preservative-free tiers over any of the soft contact lenses or rigid contact lenses. Limit reserve medications to less than 4. That includes all glaucoma medications, steroids, antibiotics, what have you. Because most of them are preserved benzalkonium chloride. The more doses you get, toxicities are dose-associated events. The more drops, the greater the dose, the greater the damage which may occur. Go preservative-free whenever possible. Questions?
Sorry, Mike. Sometimes it takes a while for me to get unmuted.
Yeah,
very good case. When it comes to piggybacks, and what you mentioned really supports the work that Barry Weissman's done to look at oxygen transmission through a piggyback, that you need a psi-high, with a hyper-decay GP on top of it. And today, what's so neat about piggybacks, when I was in optometry school and my mentor liked piggybacks, and back then it was a 5 DK polycon on top of a Bausch & Lomb U lens. So it was really like an edema sandwich.
Yes, I remember.
But at that time, you really saw the benefits in terms of being able to provide comfort and vision to those patients. And so today, it's more along the lines of, slipping a real low minus soft lens underneath the keratoconus lens to see if that improves the comfort or centration. And today that's a real blessing in certain patients, and it only takes about 5 minutes. And the knowledge that the power really has to be in the GP, because you lose a lot of it with the soft lens. And it's a tool. What you've talked about tonight is a wide range of tools that you can use. Do you, a question from Ray Brill, do you ever use a panafocal design to help with aberrations?
No, not really. Do you?
I haven't. It's certainly one of the aberration control designs, one of the tools that are out there. There's just so many today. I remember years ago there'd be an article on here's 5 different corneal GP designs you can use, and now we have all the ones that you talked about tonight.
I still find it useful, and it actually, part of the beauty of the scleral lenses, this new technology that I still call it new technology, been doing it since what, 05 I think, is it's so much easier to fit. And fitting corneal GP lenses requires a lot more talent, experience to do it right and get that feather touch, for example, over a cone without breaking down the tissue. You have to be much more exacting, just like in those who fit PMMA lenses back in the day, and that was actually before me. PMMA lenses, well, you really, since you had an absolute oxygen barrier you're putting on the cornea, but a properly fit PMMA lens worked great, and you still can't beat the optics of PMMA. And I have a few patients still in PMMA who I could never get out of PMMA, and as long as it's not having any corneal edema, which brings a whole other conversation to hold, are we doing anything long-term to the endothelium or not? But if they're not having any edema and they're happy with their vision, anything I do in taking a successful PMMA lens wearer is going to make them worse if I try to put them into one of the modern plastics. And that's sort of like another consideration, taking another branch off that as I go off skirting to the side here onto a tangent. But following that tangent line, in patients who are rigid contact lens wearers, corneal or now scleral, prior to cataract surgery, it's really important that you have the discussion with these patients that those who have been spending decades, for example, wearing rigid contact lenses, see at a higher bar. They are accustomed to better vision than what LASIK surgery or cataract surgery or any kind of soft contact lens can provide. Quite simply, the rigid Gazprom lenses provide the best possible vision that the eye is capable of beyond a pinhole. And when they're used to seeing at that level, anything else is just not going to be quite right. Have you run into that? I'm sure you have.
Yeah, it's when you set the bar that high, I think that's well said. We do have some questions. Debbie has a good one. She's one of our outstanding residents, and this is one that she had a question about scleral lens designs and any preference for the semi-sclerals, and she defines as like the 14.3 to 15.6 type diameters versus the larger like 18 millimeter or greater diameters. She sometimes finds some mid-peripheral indentation staining on the cornea with the smaller designs. Have you noticed similar problems with fitting the semi-scleral?
Yes, it's a very good question. When early on in going into, as we're tiptoeing from corneal into scleral designs initially, you didn't want to go too big. You feel scared of these things getting too big. But the reality is, number one, you really have to have good clearance over the limbus. And so I find that I don't fit 15 O's anymore. I did for a short period early on, back maybe 2005, 2006. I don't, and it's really uncommon. Only rarely will I use somewhere in the 14.5 to 15 area. Most scleral lenses work between 16 and 18. 16.5 is probably the most common diameter that we see, that we use. Again, 16, 16.5, 17 to 18. You must have full clearance over the limbus. I can't overemphasize that. Look at your vasculature, but really, because you got the advantage of fluorescein stained tears underneath to be able to check that fit, but you have to. The most important viewing is the first follow-up visit post-dispense. When the patient's had the lens on for a number of hours, hopefully you're going to see them in the afternoon. They've had the lens on for a number of hours. They come in wearing the contacts, of course, and you can see with the lens will have settled, maybe as much as 100 microns. You will have lost in your chamber depth, and that's where you really want to look carefully. And then after you look at the lens, take the lens off, look at the cornea, stain the cornea, and if one gets corneal staining, you may not have recognized it, but that's probably where you're getting some touch during the day as that thing settles down. And that's just not acceptable. Now, you can actually, and this is debatable, or controversial, I should say, and that is you can actually have some feather touch with a scleral lens, and it works okay. Any comments on that, Ed?
No, I think that is well said. And it seems like the people such as yourself who are very experienced scleral lens fitters do gravitate toward the bigger designs, particularly in very irregular corneas, and gravitating more toward toric peripheries and some of the sophisticated peripheral designs that these labs can make. The next question Gerald asked, and I'm sure this is just dependent on what design that you use, but he did ask what determines your initial base curve and diameter in a scleral lens.
Great question. Not a good answer, but a great question. I look at I get a feel for how much sagittal depth I want. If it's a cone, is it a Saltzman's dystrophy or a granular dystrophy? Is it a Sjogren's or something else that I'm trying to manage? I want to look for I want a couple hundred microns of space between the posterior contact lens and the anterior cornea. And I want a minimum down to 100 after it's settled. So I'm looking for about 200 to 300 during the fitting process. That said, there's no good way. Our topographers cannot help you here. Topographers tell you, don't give you true elevation, at least not the ones we use. They don't really give you true elevation. They give you relative curvature, which is interpreted as elevation. And similarly, the keratometer gives you relative curvature. It doesn't give you true elevation. So you really don't know until you put the lens on the eye. I like Steve Burns' comment on that. He says, take your fitting set, take the middle lens, put it on and look at it, and then let that guide you. Or have the patient look straight ahead, 90 degrees off, look at them from the side, and see, yeah, is that a normal? Is that a flat, medium, or steep? And that's where I'll start. There's no magic on picking your first lens in there. As far as diameter is concerned, one will acquire a feel for that's a big cornea. Now you can measure the corneal diameters. That's pretty scientific, actually more scientific than I use on these. I just kind of eyeball it, sorry for the pun, and say, okay, that's a normal. Normal's about 11.8 millimeters, and am I going to want good to go big? Now one thing that heads me towards the larger lenses, if I'm seeing some blanching, let's say I put a 16, 16.5, or 17 on the eye, and I'm seeing a little bit of blanching. If I increase the overall lens diameter and therefore increase the surface area by which that pressure will land on the sclera, I will have less pressure at any given point. I am less likely to have any blanching that way. So I want to spread that pressure over a larger area. There'll be less pressure. There'll be less blanching if that's of concern. And that will head me towards an 18, 18.2, 18.4, somewhere in that regard. 16, again, 16, 16.5, 17, those are really good places to start on these lenses. And you need fitting sets up through 18, or at least to 18, to be able to do this properly. And do yourself a favor, when you think you've got a good fit, for example, in a 16.0, take the extra couple of minutes and put an 18.0 on also, and just look at it. It may look worse, it may look better, but you'll learn something from it.
All right, very good. Scott Hagen asked a good question. Your thoughts on toric sclerals? We know that there are certain cases where we have significant residual astigmatism, and they can utilize a small amount of prism and correct for the cylinder on the front surface. Is that something that you've done frequently? Are there challenges?
Of course, everything has a bit of a challenge, but that's what makes it fun. That's the good stuff. Mm-hmm. I've had really good luck with front surface torics and using toric peripheries on these, and it's amazing. Even as little as a half diopter, but typically, like in a regular scleral, you're looking, or on a regular toric, you're looking for about 3/4 of a diopter more of cylinder residual that needs to be corrected. Some people are just finicky, and that half diopter, 3/4 of diopter is really important to them, and we've done it. I just did one, 3/4 of diopter yesterday on a patient with a front surface toric, and they love it. I've been extremely lucky, maybe, that the labs have been able to cut what we're asking for. And again, your laboratory consultant can help you here and helping to design these things. If you tell them what you got, what your diagnostic lens was, their parameters, what your over-refraction is, describe what you're seeing in the way of your vault, your sagittal depth, and what your over-refraction is, and they can help you out here. And be sure you take a K reading, because if you're getting cylinder, make sure it's not flexure, because it can be misinterpreted as that.
Okay, very good. Any other cases, Mike?
No, I think I've got some other post-refractive stuff, but I think we'll stop here.
All right. We'll end it then at this time. I really want to thank you. This was an outstanding clinical presentation. I think your expertise is very evident, and you do it in such a relaxed manner, and then you certainly in answering the questions, I think, gave our our audience, and I can tell that by some of the comments they're making, answers that they greatly appreciated. And what's also very comforting is that you do use a large number of tools when you approach these different patients. And for those of you who are not there at the beginning of the webinar tonight, Michael's been fitting lenses for a long, long time, but he's evolved. He used the PMMA term. I remember that term. But he's evolved into using sclerals as one of his primary options on many of his newer irregular cornea patients. And you had the Novacone example. You had examples where piggybacks, all these different tools, and really truly was an outstanding clinical presentation on a topic that everybody's interested in. We all have irregular cornea patients. We're all wondering, what do we do, and what tool do we use, for what patient? And I think what these cases did is helped orient us toward, what our priorities should be in particular types of cases. And for that, we really thank you.
Thank you, Ed. I appreciate it.
It's wonderful to have your expertise to help us in this area. And really, you emphasize the benefits provided by your laboratory consultant. You just mentioned that they're always there to help us, and there's no dumb question for the laboratory consultant. And also, as we mentioned, the increased use of scleral lens designs, and we've seen that just absolutely take off. We know in the Global Specialty Lens Symposium every year, and Michael and Betty Russell always do a program on sclerals, and these are the types of programs we're bringing chairs in. It seems like in a couple of months we're going to be bringing Clark Newman back to do an update on coding and billing, and that's the other presentations that we always need extra chairs for in these areas of great interest to people, and certainly that's an area that is booming. So with that in mind, on behalf of the CLMA, I want to thank all of you for participating tonight. Please come back and join us on July 22nd when Drs. Mile Bruchek and Dave Kading will present on a topic that is a great piggyback for tonight's basic clinical considerations in scleral lens fitting. Thanks again, everyone. Have a good evening, and we'll see you next month. Good night.
Thank you. Good night, all.